Hello, and welcome to the Malignant Hypothermia Association of the United States' very first patient-oriented webinar. My name is Sarah Prosser, and I am here today with Tina Rolla from the House office, along with one of our MH experts, John Capicchione from the University of Minnesota, and Lydia Friedman from the House Patient Liaison Committee. Before we get started, Tina is going to go over some minor housekeeping items to help this webinar go as smoothly as possible for everyone. Tina?
Hi, everyone. Before I go over the housekeeping items, I want to be sure that everyone can hear us. If you can hear us, click on the hand symbol in the control panel in the upper right-hand corner of your screen. It's a yellow hand with a green arrow. I'll give everybody a few seconds to click the hand. Okay, looks like most of you can hear us. If you're just joining us, I'm asking you to click this hand to let us know that you can hear us, the hand symbol in the control panel. If you cannot hear us, go ahead and send us a message on the chat. We're going to go ahead and move on. So now let's get to those housekeeping items. The orange arrow on the control panel will open and close the control panel so you can see the full screen. The question box right here is where you will submit any questions that you may have. Our goal is to answer every question that comes in, but if by chance we do not get to yours, don't worry. We will respond either in the chat or via email. This webinar is being recorded and will be placed on our website at a later date. Okay, let's get started. Sarah?
We are very excited to be providing this webinar today for MH-susceptible patients and their family members. We all know MH is a rare and scary genetic disorder. The topics we will be discussing today with you are awake MH, MH testing options, and heat-related illnesses and their relation to MH. There were many questions submitted for this webinar. We will be answering as many as we can. As Tina said, if your question is not answered during the webinar, please stay tuned for an email containing the answer within 2 days. John and Lydia, it's so nice of you to volunteer your time to help us with this webinar. Please take a moment to introduce yourselves to our audience. John?
Hi, my name is John Capicchione. I'm an anesthesiologist at the University of Minnesota. All of my formal training occurred in the United States Navy, and I was on faculty at the Uniformed Services University of the Health Sciences for the past 12 years. The Uniformed Services University is one of the 4 U.S. MH testing centers. They do all the evaluations for malignant hyperthermia, heat stroke, and exertional rhabdomyolysis for the Department of Defense. They perform the caffeine, halothane contracture test, and they do genetic testing of RYR1. I was there, as I said, for about 12 years, and I left as the director there this past July and joined the University of Minnesota. The University of Minnesota just happens to be another one of the 4 MH testing centers in the United States. So I have now worked for 2 of the 4 MH testing centers. My area of expertise is in heat stroke, heat illness, and exertional rhabdomyolysis, and its application to malignant hyperthermia. Thank you.
Thanks, John. Lydia?
Hi, my name is Lydia Friedman, and I've been a volunteer with House for a little over 30 years. I became involved when my youngest daughter had an MH episode. As a volunteer, I try to respond to all the answers and questions and concerns that individuals place on the MH website. I try to personally also call each individual and talk with them and let them know that what resources are out there, as well as the people that are at House try to help them. Thank you.
Thank you, Lydia. Also during this webinar, we will be testing your knowledge of MH with a few random poll questions. Be sure to watch for them, as you will have a limited time to answer. Okay, let's start the webinar. Now with our first question. Tina?
Okay, thank you, everyone. Now we're going to start the webinar off with a poll question. You just click the answer. once it goes on your screen. The question is, can the muscle biopsy or caffeine halothane contracture test be shipped to a testing center? We're going to give it a few seconds so that everybody can get their votes in. Great. I'll give it about 15 more seconds here. Okay. 5 more seconds. All right, and we will close this, and I will share the results. It looks like 84% of you said that no, a muscle biopsy cannot be shipped to a testing center, and 14% said yes. John, can you talk about that a little bit? I'm sorry, 16% said yes.
Sure.
Can you talk about that?
Sure. This is a bit of a confusing concept, not only for patients, but for providers. I would say about once or twice a year, we will get a call from someone somewhere in the United States who will say, I have the muscle now, what would you like for me to do with it? And the answer, unfortunately, is you've done the wrong thing. There are 4 centers in the U.S., and the patients have to physically go to those centers in order to have the muscle biopsy performed. Unlike other pathology tests for muscle where the surgeon can remove a piece of muscle, put it on dry ice, and send it to a pathologist who will then take the muscle and basically slice it, put it on microscope slides, do some staining, and look at it under a microscope. This is not true for the malignant hyperthermia test. This muscle has to be viable and it has to be contractile. So in other words, it's kind of like that frog experiment that we all did in science class where the muscle has to be able to contract. Our guidance on this is that the muscle has to be tested within 5 hours of excision. And that's why patients have to travel to those 4 specific centers in the U.S. in order to have this done. The muscle won't stay alive forever without a blood supply. And it has to be dissected out of the leg in a very, very specific manner. And most surgeons are not familiar with this type of biopsy. So the surgeons that we use at our specific testing centers have a skill in actually performing this. So in summary, anybody who's having a muscle biopsy and the caffeine halothane contracture test for the purposes of MH diagnosis has to have it performed at one of the known testing centers. The muscle cannot be excised at a non-testing center location, put on dry ice, and mailed or sent to the center for testing.
Great, great. Thank you, John. Okay, we're going to get into our Q&A slides. Is there a non-invasive test for our relatives that can determine whether they are MH susceptible? Where can we get the test? What is the cost? How long does it take? And does my insurance cover it? I'm going to send this to John first to cover the first part of it. John?
Yes, there is a non-invasive test, and that is the genetic test. The genetic test is not foolproof, though. The sensitivity of the test right now isn't as high as we would like it to be. So what happens is if someone has a clinical episode that we suspect was MH, we have to make a decision. Do we send the patient directly for genetic testing, or do we send them directly for a muscle biopsy? The genetic testing can be done with either a blood sample or a buccal swab, which is basically taking a cotton tip applicator and scraping the inside of somebody's cheek, and then the DNA from those cells gets isolated and DNA testing can be performed. The problem with genetic testing is that just because you have a negative genetic test doesn't mean that you're negative for MH. There are genes and other mutations that we know are associated with MH that we just haven't been able to identify yet. So if you're negative on the genetic test, that doesn't mean you are not negative. The Muscle biopsy test is the only validated diagnostic test that exists presently for MH. So what we'll often do is we will take the index case, that person who has had a clinical episode of MH, we'll perform a diagnostic muscle biopsy on them, and if the test is positive, we will then test the remaining muscle for any genetic mutations that may exist. If we don't find a genetic mutation, then every other family member related to that patient must have a muscle biopsy. If we do find one of the known MH-causative gene mutations, we can then spare the rest of the living relatives the need for a muscle biopsy by simply taking a blood sample or a buccal swab, isolating their DNA, and looking for the same gene mutation in that patient that was found in the index case. I hope that made sense.
Yes, yes, it did. And to the audience, be sure to ask any questions in the questions box if you need further clarifications on anything that we talk about. Lydia, what do you think about the insurance part? What do you feel about the insurance carrier, and how should they go about seeing if the insurance will cover a test?
When individuals ask me about the testing and then the coverage of the cost, I tell them first thing is to call their insurance carrier. Speak to someone having the information in front of them of what exactly MH is in case the insurance carrier personnel is not familiar with it. Find out if they do cover any testing, genetic as well as the muscle biopsy. If you're interested in the genetic testing, you can get information on the website and then have the insurance carrier let you know if they would cover this test. The prices do vary. There are the two centers, and I also tell individuals to call the two centers to get information from them as to the forms and the exact cost on their end. The price does vary, and it's something that you do need to make sure you have. There's also forms on the mHouse webpage that can be submitted to the insurance carrier yourself, or have your primary or your physician that's treating you submit the form, which might help with getting the coverage in case there's any hesitation on the insurance company's part.
Great, great.
I just want to add one other thing. There's a cost-benefit, risk-benefit to all of this. For instance, the muscle biopsy caffeine health and contracture test is the most definitive and the most validated. It's also the most invasive. But even if your insurance company is going to pay for the hospital costs, they won't pay for your travel and lodging. So if you live in a location remote from one of the testing centers, you still will have the expense of travel and lodging, and your medical insurance won't cover that. With the genetic test, you can mail it off. You don't have to physically be present to be tested. The problem with the genetic test is, while it is less expensive than having an invasive muscle biopsy, if it comes back negative, you still don't have an answer. If it comes back positive, great, you lucked out and it was less expensive. But you could go to the expense of genetic testing, not get a positive result, and still have to resort to doing the muscle biopsy.
Right, right. Great, thank you, thank you. The next question, how many generations does MH go back, and does the likelihood of MH in the family get to be less with each generation, or does it continue just as strong as the first? John, what do you think about this?
MH is inherited in what we call an autosomal dominant pattern. In other words, if one of your parents has it, there's a 50% chance that they're going to pass it on to you or your siblings or any of their offspring. You'll have probably heard about this genetic testing center called 23andMe. The 23 stands for our number of chromosomes. So we get half of our chromosomes from our mom and half of our chromosomes from our dad. And which half we get is actually very random. So if your mom carries one of the mutations for MH, there's a 50-50 chance that she's going to pass it on to her offspring, because she only passes half of her chromosomes on to her offspring. So if you do the math and a couple who has one child, and one of the parents carries the mutation for MH, if that one child is lucky enough not to get it, guess what? MH stops with that generation right there. If you did not inherit it from your mother or father, you can't pass it on to the next generation. Let's say a couple who carries one of the gene mutations has 5 kids. Each of those 5 kids has a 50-50 chance of inheriting the mutation. Some may inherit it and some may not inherit it. Those who don't inherit it, it stops right there. It does not get passed on to their progeny. But those who did inherit it have to have a 50% chance of then passing it on to their progeny as well. So it's conceivable and it's possible that it will stop with the next generation if the next generation does not inherit the mutation.
Great, great. Thank you. Lydia, I know that your daughter is MH positive. Can you talk a bit about her susceptibility and if she passed it to her children or where she got the MH susceptibility gene from?
Sure. My daughter, I have 2 daughters, and my youngest was going in for tonsils and had an MH episode. We were very lucky and blessed that she came through it okay, and she had no side effects. She's now a grown woman. She does not have children. However, while growing up, the biggest fear and concern was if something should happen. So she now is doing just fine. She does wear a medical alert bracelet. She did have the muscle biopsy, and come to find out, she inherited this through her father. My husband also had the biopsy, and he was positive. And what John was saying is that one sibling will have it, possibly inherit the gene, and the other might not. My oldest daughter did not inherit it, so she does not have MH, and she was also tested through the biopsy. She does very well, has no problems with any activities, and like I said, she's an active, healthy young adult.
Great, great. And her children, because she doesn't have it, her children also would not inherit it because it stopped with her. Correct, John?
Correct.
Correct. So,
okay.
so Lydia has 2 daughters. One daughter carries the mutation and does not have any children. And then her other daughter does not carry the mutation. So her children are safe. There's no way for them to inherit it.
Great, great. Thank you. I do see a lot of you are sending in questions, and we appreciate it. Just know that there is a Q&A section at the end of this webinar. We will address those questions when we are finished going through the slides. Now, the next question, as a parent who has tested positive for MH, at what age is it recommended that we have our child or children tested, and what are the current testing options available? John, what age would you recommend?
So if a family has been diagnosed with MH, and if that family has undergone genetic testing, and if that family has identified an MH-causative gene mutation, those children can be tested at any age. In other words, they can have a buccal swab performed, the DNA isolated, and then the DNA tested for the known gene mutation that that family carries. If the family has not been genetically tested or has attempted genetic testing and a gene mutation was not found, then the only other option is the muscle biopsy. If that is the case, we recommend that we wait until the children are at least teenagers. The reason being is the muscle biopsy is invasive. It's not a real small piece of muscle. We do biopsy it from a portion of the thigh that does not give you any type of muscular deficit. But nonetheless, we want to wait till they're teenagers, they're mature enough to handle what's happening. And it just isn't the type of thing that you want to do in a small child because it's really not necessary at that point. We recommend that everybody take MH precautions until the patient is proven otherwise. So if your child has not been tested and the MH diagnosis has not been determined, treat them as if they are MH susceptible until they do become tested and we know definitively.
Great. Thank you. Okay, we're going to launch another poll. I know I am not MH susceptible because I have never had an MH crisis. True or false? Give everybody a few more seconds here to respond to the poll on the screen. Okay, I'm going to give about 5 more seconds for the response, and I will close it out. Okay. So this is good news. 100% of you said false. John, can you talk a bit about that?
Sure. Unfortunately, MH is one of those conditions that's characterized by I'm blanking right now. Sorry. It's expression and penetrance. So in other words, you can have MH and have variable expression and penetrance. Okay. So in other words, you can have MH and undergo anesthesia with a triggering agent and not trigger for reasons that we don't quite understand. There are cases of people who have been anesthetized with triggering agents multiple times who never triggered. And then on the third or the fourth or the fifth exposure, for whatever reason, again, we don't understand, then trigger. So past performance is no guarantee for future performance. And we hear this all the time that, my child could not have inherited MH from me because I've had anesthesia multiple times and I never triggered. That's not true. Again, a disorder characterized by variable expression and penetrance means that there is no guarantee that past performance will guarantee future performance.
Great, great, thank you.
Can I add to that?
Absolutely.
Okay, and what John has said is true, and I can validate that because my husband had had numerous surgeries through adolescent and then as an adult, and our daughter, Kimberly, was the one that was positive. So when he had the muscle biopsy and he came back positive, that was proof of the fact that it doesn't mean that you don't have it, even if you've had numerous surgeries.
Correct. Great. Thank you both. Okay, we're going to launch into the next question slide. Do MH-susceptible patients need to be concerned about dental procedures? Lydia, what is your experience about going to the dental office and finding care for MH susceptibility?
Well, for my daughters, they actually had, both of them had impact wisdom teeth, and the oral surgeon would not touch them due to the fact of the MH unless they were in a hospital setting. It does present a problem. Personally, I've experienced that to find a dentist that knows how to manage the drugs that they need to use to put a individual in a comfort zone for whatever they needed. It was a thing where they actually, with my oldest daughter, she had to get the muscle biopsy because I could not find a surgeon to take her wisdom teeth out. And so that presented another whole problem. But the understanding, just getting the information out to the surgeons, the oral surgeons, on what to use and not use is also very important.
Great, thank you. John, do the patients have anything they need to be concerned about for dental procedures?
Yeah, I think there's a spectrum of dental procedures. I mean, there are dentists who do cleanings, there's dentists who fill cavities, there's dentists who do root canals, and then there are oral surgeons who do more invasive type things like extraction of wisdom teeth. There are even, people in the dental world who are considered oromaxillofacial surgeons. if your dentist is using any of the known triggering agents, and those known triggering agents are potent volatile inhalational anesthetics, isoflurane, sevoflurane, desflurane, halothane, and another muscle relaxant drug called succinylcholine. If they're using any of those drugs, yes, there is concern. If the dentist that you go to doesn't do invasive dentistry, it doesn't use any of those medications, and you're going for a routine cleaning or a filling, the answer is there's less concern because they're just using drugs like local anesthetic to numb the tooth or to numb the gum or to numb whatever type of oral surgery that they are performing. So I guess when we say dentist, it means what kind of dentist and what kind of procedure are they doing. Like Lydia said, the oral surgeon that was operating on her children had concerns, and I'm not quite sure, what type of anesthetics he used. Nitrous oxide, for instance, which is the classic inhalational agent that dentists have been using for ages, is not an MH triggering agent, but it's also not a very potent anesthetic agent either. A lot of them don't even use it anymore because it can cause nausea and vomiting. So I guess I have to qualify, what we mean by dental procedures. Cleanings, fillings, root canals, where none of the MH triggering agents might be used, you're very, very safe. If it's more invasive and your oral surgeon wants to use any of those agents, then there is concern.
Great, thank you. Our next question is, I have read that if you have a second MH reaction, it will be faster than the first. Is this true? John?
I don't know. I've never seen this question before. I've never seen any literature on this, and whoever wrote the question, I'd like to know where they read that. And the other thing is, what is meant by faster? The reason I say that is because different people present in different ways. We have documented cases of people who developed MH crisis immediately on induction of anesthesia, and it was very, very obvious to everyone in the room. We also have documented cases of people who didn't develop the MH crisis until almost 10 hours into a very long procedure. So what is meant by faster, I'm not quite sure. Having an episode on induction of anesthesia is about as fast as you can get, and developing it 10 hours into a case is about as low as it can get. And remember, MH is a very, very, very rare disorder, so there isn't a lot of data with absolute comparisons, especially in patients who've had multiple exposures and multiple episodes. Presumably, no one should have a second episode during anesthesia because proper precautions should be taken after a person has been diagnosed and it's been recognized that they've had an episode in the past. If we know that someone is MH susceptible, they should not get a second anesthetic with a triggering agent. So it's a bit of a confusing question for me, and that's about the best answer that I can give.
Okay, great. We do know who sent in the question, so I will be sure to follow up after the webinar. Okay. The next question is, what has been the long-term effects and outcomes for people who have survived a fulminant reaction? Lydia, your daughter had a reaction when she had her tonsils out. Does she suffer any long-term effects?
No, actually, she was very, we were very lucky. She's had no ill effects from that. Like I said, it lives a very normal life, and her childhood was one that once I knew what we were dealing with and she wore her medic alert, she was able to partake in all different sports and activities. So she did very well.
Good, great. John, what do you think?
No two people are alike, and that's the confusing thing for everybody. You hear this all the time where some people can tolerate some things and some people can't, and people don't understand that. It's almost like your kids. Some might like green beans and others don't. I mean, we're all very, very different. And even though patients may share the same MH gene mutation, that doesn't mean that they share all of the same DNA. Since we're all very, very different, we all respond very, very differently in spite of the fact that people may share the diagnosis of MH. So there are people who experience little or no problems at all. Most people don't even know that they're MH susceptible before they even have an episode. But then there are some people who do develop long-term sequelae, as we call it, long-term muscle pain and cramping. But there is no real way to predict who will and who won't until it actually happens. So, the answer to that question is we really don't know who will develop problems or who won't until they do.
Right. Great, thank you. Next question. If I tested MH positive, do additional symptoms happen as the person ages? John, what do you think about this one?
So I am unaware of any long-term study that has actually compared MH-susceptible patients over time to a control population of similar age to see who develops problems and who didn't. So again, it's difficult to say because not all MH-susceptible patients will have awake-like symptoms. And the other thing it's hard to differentiate is if the aches and pains that we develop as we age are related just to aging or if it's related to MH. I'm in my mid-50s now and I have pains in places I didn't have pains in 10 years ago. So I don't think that I'm MH susceptible, but the aging process does things to all of us. So to be able to say that with aging things are going to get worse, we really don't know that, and I'm not aware of any study that has actually shown that either.
Great, thank you. Okay, it's time for our last poll question. I will put it up on the screen and give everybody a few seconds to answer. Can an MH event occur outside of the operating room? Okay, I'll give just a few more seconds for everybody to respond. Okay, I'm going to go ahead and close that poll. 91% said yes and 9% said no. John, what do you think about that? Can you elaborate a little bit about MH outside of the operating room?
Sure, it's a kind of a trick question because there are people who will say by definition MH occurs in the operating room. They'll say MH is a disorder of muscle metabolism that is triggered by certain drugs that we give for anesthesia. If you use that strict definition, MH can only occur in the operating room. However, the definition of MH has kind of evolved and kind of changed because we know that it's a genetic disorder of skeletal muscle metabolism. We were very naive for many years when we told people that, oh, don't worry about it, you'll only have a problem if you go to the OR for surgery, and we know that you're MH susceptible, so we won't give you any triggering agents, so you have nothing to worry about. Kind of a bit of a naive approach when you think about it, because we know that whether you're being exposed to a triggering agent or not, your calcium regulation in your muscle isn't quite normal. So there are people who have absolutely no problems in their lives without exposure to triggering agents. However, there are people who do develop muscle pain, muscle fatigue with exercise, heat intolerance, greater susceptibility to heat stroke and heat illness, and a condition called exertional rhabdomyolysis where the muscle actually breaks down with exercise. But in terms of the classic manifestations of MH that happen during anesthesia, that is atypical outside the operating room. There are people who would like to call it an MH-like event. In other words, you do develop rhabdomyolysis and your temperature goes up, but you don't develop all the similar manifestations that you would do under anesthesia. A caveat to all of that I want to tell you is a young child in Florida who on a, I would say 78-degree day was playing outside and did develop the rigidity and the hyperthermia and the metabolic crisis that would typically come with an anesthetic exposure. But that's very, very rare, but it has happened.
Great, great, thank you. Okay, we are going to go on to our next round of Q&A slides. The question is there a way to determine if muscle cramping or fatigue is caused by MH or by a thyroid issue? John, how do you tell the difference?
I'm an anesthesiologist. I'm not a primary care provider. So if this question arises, my recommendation is that you contact your primary care provider and get a referral to a neurologist and an endocrinologist so they can do muscle testing and thyroid testing to try to differentiate the two. The neurologist can do certain things like EMGs and nerve conduction studies and do other screening parameters, measure your CK to see if there's any muscle death going on. And an endocrinologist can actually do your thyroid hormone testing to determine if that is the case. So my recommendation is to see a specialist in neurology, one specifically who has expertise in neuromuscular diseases and disorders, and to see an endocrinologist who has expertise in thyroid disease.
Great, great, thank you. Next question is, what guidelines are there for the doctor in considering oral dantrolene regarding the dosage? John, what do you think here?
This is similar to the last question. I am not a neurologist. I'm not a primary care specialist. I'm an anesthesiologist. So my recommendation when someone thinks or wants to pursue oral dantrolene because their awake symptoms of muscle pain, fatigue, or cramping are so great that a neurologist should be evaluating them. Now, my observations in basically dealing with some people who are on oral dantrolene is that the neurologist will start out very low with a 25 milligram dose per day and escalate it slowly. This medication isn't benign. It can have some side effects associated with it. And really what we want to do is to optimize the benefits and reduce the side effects. So if they do get a response to 25 milligrams per day, then great, no more is needed. However, if they don't get a response, typically escalating doses are given in a very slow manner in order to optimize the beneficial effects without causing any adverse side effects.
Great, thank you. What are the symptoms, what are the non-anesthesia symptoms of MH? Lydia, has your daughter had any symptoms of malignant hyperthermia outside of the operating room?
No. She's, like I said, she's been very fortunate in that she's led a very normal life. She's never had any problem.
Good. When you talk to our patients, our MH susceptible patients, what do you hear from them? What seems to be the consensus?
Some of them do have, when they've had for non-anesthesia symptoms?
Correct.
Or for after they've had anesthesia?
For the non-anesthesia symptoms of MH.
I really haven't spoken to that many individuals with that occurring. Most of them are individuals who have been under anesthesia and had problems, or their children or another family member. But I've not really had too much contact with anyone with that.
Okay, okay. John, what would you say about the symptoms of non-anesthesia?
I would just reiterate what Lydia said, that most people who are MH susceptible don't even know that they are MH susceptible and have no symptoms whatsoever. I mean, even those who've had an episode, don't typically develop any awake sequelae. However, there are people who do complain of muscle cramping, pain, twitching, fatigue, even sometimes heat intolerance. When we're trying to evaluate people to get a gestalt, so to speak, of whether we think they need to be tested or not be tested, we kind of ask those questions because it kind of paints a picture for us. One of the other things we always ask, are you athletic? Are you very muscular? Are you very lean? Because there seems to be a correlation between people who are very muscular, very athletic, and have lean body weight with MH susceptibility as well. So some of those people who do have problems, as we mentioned before, there is an association between some of the exercise-induced illnesses, such as heat illness, heat stroke, or exertional rhabdomyolysis. But by no means do all people who are MH susceptible have these symptoms or these problems. And by no means do we have any way of predicting who will and who won't.
Right, right. Great, thank you. So to lead off of that, the next question is, how much exercise, if any at all, could trigger an MH reaction? John, could you elaborate a bit?
Again, we don't know. Everyone is different. As I said before, even if you share the exact same gene mutation with someone else who is MH susceptible, that doesn't mean you share the rest of your DNA. And some of that other DNA may offer you some protection in some way that we just don't understand. Why some people develop the crisis immediately upon exposure and some are delayed, why some of them have it on their first exposure and some don't have it till their fifth exposure. We don't quite know why. But there are some people who will develop problems with exercise. We don't discourage exercise because that's unhealthy too. We don't want people to sit on the couch and become couch potatoes. We want them to enjoy life. We want them to do the things that they want to do. I say this to everybody. Unless you're a professional athlete and you earn your living by your athletic prowess, the purpose of exercise is to stay fit. And everything that we do should be done in moderation. If you start to feel sick or if you start to feel bad as you're exercising, people should stop. Humans are the one species who will exercise themselves into a crisis. I know of no other animal species that will do that. Animals are kind of smart. When they start to feel bad, they stop doing what they're doing. Humans have this philosophy of no pain, no gain, which is a bad philosophy. If things are hurting you or you're feeling bad, that's your body telling you it's time to stop. And especially if you're an MH susceptible patient, you don't want to push yourself to your limits. So exercise rarely triggers MH, but there may be an association, as I mentioned before, between heat-related illnesses and exertional rhabdomyolysis.
Great, great, thank you. Is weight training with free weights an issue for my son if he potentially has MH? John, what is your opinion on this one?
It's potentially an issue for your son whether he has MH or not. As I mentioned to the last question, exercise in moderation is good. Exercise to extremes is not good. There are people who will exercise themselves into rhabdomyolysis with something called CrossFit who are not MH susceptible. That's not good for you either. So what I would say is, yes, there's a potential for a problem if he has MH. There's also a potential for him if he doesn't have MH. So there are other risks associated with exercise if you're exercising to extreme. Would I discourage him from weight training? No, but I think you need to be careful. I think you need to do it in moderation. I think you don't do it to extreme.
Great, thank you. Okay, now we are going to open it up to some questions. Thank you both, John and Lydia, for your input so far. We've gotten quite a few questions in, so I'm going to start with, Don asked, Where is the genetic testing done, and is it covered by insurance? Don, I can answer the first part of that question and say that the genetic testing centers can be found on our website. So simply go to www.mhouse.org and click on the testing tab. And is it covered by insurance? Well, that depends on your insurance company. So make sure that you call your insurance company for more information. Don also says, I have 2 adult children who need to be tested. What awake triggers do I need to be concerned about, and how often do they occur? John, can you elaborate on that one?
Yeah, we don't know how often, and the reason is that MH is a rare disorder to begin with, and then who will develop awake-like symptoms is even rarer, and often it isn't even reported to us. So we only know things on a case-by-case basis. We don't really have a whole lot of great controlled studies to look at this, and that's unfortunate. I think, as we have mentioned, the things to look for are heat intolerance, to look for muscle fatigue, to look for pain. The other one that we didn't mention is dark urine. If you're dehydrated or you're having muscle breakdown, you can develop something called rhabdomyolysis. And your dark urine is due to something called myoglobin that's in your urine. That's an enzyme that exists in your muscles that actually gets released from the muscles when they die. So we always kind of ask that question, did you develop Coca-Cola colored urine? If you did, that's a sign of rhabdomyolysis and a cause for you to go to the doctor and to go to the emergency room to be evaluated for that.
Great, thank you. Another question we have, I want to interject that we are at 2:48 p.m. Eastern Time. We will wrap this up about 10 minutes. Those of you who have submitted questions that will not be answered by John or Lydia today, we will submit an email to each of you with a response. We have time for probably 1 or 2 more questions, so I'm going to read a question from Julie. I didn't have a muscle biopsy, but instead started with genetic test. I tested positive for MHRYR1 on the first tier of testing. This is still a valid confirmation of MH, right?
My question to Julie would be, why was she MH tested? Was she tested because she had a clinical episode or because a family member had a clinical episode? If it was a family member who had a clinical episode, I would recommend that that family member also be genetically tested, as well as other family members who are not suspected of being MH susceptible. The reason is that we need to make the genotype-phenotype correlation. The phenotype is the clinical manifestations or a positive contracture test. The genotype is the change in the DNA. I would like to say that she is, but I don't know what her gene mutation is. That can be looked up on the European malignant hyperthermia website. They list 34 of the known MH-causative RYR1 gene mutations. If she has one of those 34, then I would say yes, that she is MH susceptible. Again, without knowing the rest of her history and the rest of her family history, and not knowing what gene she's referring to, I would hesitate to give a conclusive answer.
Okay, we can certainly follow up with Julie after the webinar. Kevin would like to know, he had the muscle biopsy test and it was inconclusive. What does it mean to be inconclusive? John?
I don't know where Kevin had his test performed and in what year he had his muscle test performed. The test has gotten refined over the years and it's been modified over the years. There was a test that was formed in Boston several years ago that has now been invalidated. And unless it was the actual caffeine halothane contracture test, I don't know what to tell him. I would want to look at the report and look at the center that performed it before I could tell him what inconclusive meant. There's very specific guidelines on how we interpret the contracture test. And without having that data in front of me, I'm not quite sure why his test is inconclusive. unless, of course, it was performed at the Boston Center many years ago and it wasn't an actual caffeine health and contracture test.
Okay, okay.
We need to follow up with Kevin with more specific information.
Absolutely. Okay. Let's see. I'm just looking through a few more questions. Okay. We have a question from Scott. How much does the CHCT typically cost if you have no insurance? So is there a cost range that you can give, John, or is it really dependent on each individual case?
Yeah, it's not each individual case. It's probably more each individual center. I can tell you this. We went through this a couple of years ago with someone who didn't have insurance, and at USIS at least, the only people we could test at USIS were active duty and dependents of active duty, or retired military. So we couldn't use our hospital to test civilians. So we have a memorandum of understanding with the Children's National Medical Center, whereby the patient goes to their hospital, has the biopsy performed, and then the contracture test is performed back at the Uniformed Services University. So to give you an example of what the price estimate was at Children's National Medical Center, it was close to $20,000, okay? Now that's what they would say that they were going to charge the insurance company. They were giving discounts if people were paying it out of pocket. And why, I don't know. I can't give you information on that. I don't do budgets or anything like that. But I know that the cost got down to as low as $10,000 for out of pocket.
Okay, great. Thank you, John. Okay, we are going, I'm sorry.
Still very expensive.
Okay. We're going to go ahead and wrap up the webinar. I understand there are still some questions out there that haven't been answered. We will answer all of them either in the chat or email after we have ended the webinar. Sarah and I would like to thank you for joining us today. We hope this webinar was both informative and enjoyable. We've received quite a bit of feedback from our patients stating that they don't know what to ask during a preoperative appointment. In response, we've put together a patient safety checklist for everyone. If you look in your control panel under the handout section, you will find the checklist. Just click the link and save it to your computer. We hope that this checklist will assist MH-susceptible patients be their own advocate during their appointments. Please call our office if you have any questions regarding this checklist. Now here's a quick word from mHouse's Executive Director, Diane Doherty. Diane?
Thank you. Good afternoon, everyone. This particular webinar has been a staff goal at the mHouse office in upstate New York for a while now, and it's wonderful to see it completed. I would like to take a moment to thank both Dr. John Capacchione and Lydia Friedman for sharing valuable insight from both the clinical perspective and the patient's viewpoint. In addition, Sarah and Tina have worked very hard to make this become a reality, and I want to thank them for their hard work. I hope everyone attending is able to take away at least one new piece of information or clarification of a question or concern you might have had. The Board of Directors of mHouse and staff plan to provide more webinars in the near future. We're considering making them a quarterly event, focusing on only a few questions to allow for a thorough response, just like this one. There will always be time for impromptu questions and answers, of course. If you feel this webinar was worthwhile, please consider becoming a member of mHouse. Patient membership is only $35 a year. We're a membership-based organization and focus on assuring patient safety from a devastating MH event. Members receive 30% off most of our MH educational resources and a quarterly newsletter. Our website at mhaus.org offers much in the way of MH information and a way to reach us via the contact button at the top of the site. Here you can ask a question of a specific person, like myself, Tina, Sarah, or an MH expert. We welcome tax-deductible donations to mHouse. They provide a solid base for us to continue our webinars like this one. Thank you all for attending, and please feel free to share your feedback on how well you feel we did, and if you have suggestions for improvements to the process or ideas for future webinars. We would be happy to hear them. Again, thank you to the presenters and MHouse staff for your efforts and dedicated time to make this event so successful. I hope everyone has a wonderful rest of the day and week. Take care.
Great. Thank you, Diane. One last thing before we end the webinar. I would like to ask you all to complete the short survey that will pop up on your screen when you close the control panel using the X in the top right corner. We appreciate your support and wish you all a wonderful afternoon. Thank you.